Well, I'd like to thank the organizers, Dr. Viraj and Dr. Jagdish Kothari, for giving me this opportunity to moderate this panel on this gastrointestinal NENs. Well, the neck cancer is always compared to a zebra, which is rare. So the zebra really represents all the rare cancers, and not all cancers are pink like breast cancer. So what is important is that the incidence of neuroendocrine neoplasms is on the rise. And this oft-quoted publication of Arvind Dasari from the SEER data shows that along with the lung nets, all the gastroenteropancreatic neuroendocrine tumors are also showing a rise, as is shown here, where the small intestine, stomach, the cecum, appendix, colon, and pancreas, rectum, all are on the rise. You can see that the small intestinal neuroendocrines form a large part of the JEPNET, whereas then you have the pancreatic nets, the gastric nets, and all the others. So this is the important epidemiological data. The reason for the rise is really, I think, more an awareness and better diagnostics as well as therapeutics. So I would like to begin the panel discussion by asking our panelists. So let me begin with Dr. Nagendra Sharma. What is the update in the classification of JEPNEN, which has occurred in 2019? How has it changed as compared to the previous, can you give us some update on that?
Okay. So the updated classification of GEPNet now basically especially for the gastrointestinal type, we are having two classifications. One is European and other one is from the other country, American, which we usually follow, in which grading is also a part of staging. Now, basically they are divided into, like for gastrointestinal PNETs, we are having like foregut, midgut and hindgut PNET tumors. Based on that, we will basically classify what is the site of origin. Based on that, what is the grading, grade 1, grade 2, grade 3, and what is the Ki-67. These parameters are taken into consideration in classifying the GEPNet.
So, Dr. Randeep, can I ask you to add some more to this information? Dr. Randeep?
Hi, ma'am. I think the main change which has happened. Hi, ma'am. Good evening.
Yeah. Good evening.
I think the main change which has happened is that earlier we were very confused that how will we be treating a grade 3 tumor, because there was always a dilemma of 20 to 50%. Though the new classification has not defined that, but yes, they are definitely told that the grade 3 has been divided into NET and NEC depending upon the degree of differentiation on histomorphology. And if you have more than 20% and your morphology resembles that of neuroendocrine tumor, there is something called grade 3 NET, which has come up, which was earlier not there. Anything which was more than 20% was called neuroendocrine carcinoma, but now we also have a neuroendocrine tumor in more than 20% key index. That was one of the major change. Other is that earlier we always used to believe that the term was there manic, which was mixed endocrine and neuroendocrine carcinomas. That term has also been changed to MINEN, which is mixed mixed neuroendocrine and non-neuroendocrine neoplasms. So earlier there was always a belief that we will see always adenocarcinoma and neuroendocrine carcinomas together, but now you can even have adenomas and neuroendocrine tumors together. So that term has been changed to MINEN, and MINEN has become a very broad term, having collision tumors, pushing tumors, and composite tumors, having adenomas and neuroendocrine tumors and carcinomas together.
So I think the very important offshoot of this classification is the division of NET G3, I mean the G3 grade 3 tumors into NET G3 and NET G3. And we know that their behavior is quite different and the approach also has to be different. So I think this is the most important difference between the previous classifications and now, and the addition of MINEN. Now the good news is the 5-year overall survival has also improved in the distant metastatic GI and pancreatic NET. As you can see that, the hazard ratio is 0.06 for the distant GI NETs and even for the pancreatic NETs. And in the pancreatic NETs, the improvement also coincides with the introduction of the TKIs. So these are important good news for us as far as the neuroendocrine tumors are concerned. So, with the multiple options, which the previous speaker has also mentioned, it becomes very confusing for the treating physicians to find out what is the best option and what is the best sequence. So I thought it's best to bring about this by discussing all the options through two very important clinical case studies. So let me begin with this case study. This is a 60-year-old female, a known case of hypertension, and she presented with intermittent flushing of the face, mood fluctuations, poor control of hypertension, headaches, breathlessness, and abdominal bloating. Some of these symptoms would last for 15 minutes and then subside on their own. So now coming to Dr. Manas Mayank,
Yes.
what do you think is the diagnosis here going by these symptoms, abdominal symptoms with these symptoms coming intermittently?
Neuroendocrine tumor would be a possible diagnosis, ma'am. So we need
Yes.
to evaluate accordingly. Yeah.
Yeah. Dr. Deepak Chabra, you're there. Can you tell us what you would suspect here with these symptoms and, the bloating in the abdomen? Dr. Deepak is there?
Yes. Are you able to hear me, madam?
Yes, yes.
So abdominal symptoms associated with some episodes of hot flushings lasting for a short duration, about 15 minutes or 20 minutes. I think my first point as a surgeon, I would be very categorical to rule out a functional neuroendocrine tumor and probably something relative more to the bowel rather than a solid organ. That is what my first impression would be looking at this short history.
Yeah. Dr. Abhishek, you'd like to say something?
Ma'am, looks like a carcinoid. The symptoms are quite classical, and most common presentation is the hot flushes. And GI, probably distal ileum, is the most common site. So we are probably looking at a carcinoid here.
Yeah. Anybody else would like to add any more information on this, on the diagnosis? So with this, what tests would you perform? So coming to Dr. Nagendra Sharma, what tests would you perform in this patient? How would you work on this patient?
Yeah, first of all, ma'am, we are going to do the diagnostic investigations followed by staging investigations. First of all, we require a adequate biopsy from the appropriate site, and the staging investigation, the suspected neuroendocrine tumor, most likely small intestine probably is the site of origin. So first of all, we require a tissue diagnosis in which proper histopathological biopsy is mandatory. Then DOTA scan, we will go ahead based on the report, and then we'll take a call. That is the KSC7, and then we can plan accordingly based on the patient's performance status and fitness.
Yeah, Dr. Randeep, would you like to add anything more for the workup?
The initial will be a CT scan, and once we know the diagnosis, once we know the mass formation is there, we will go ahead with the biopsy. I would tend to keep a PET scan later on, depending upon the biopsy report, as we also know that these are functional tumors, and sometimes, usually we do order a DTPS scan. I'm so sorry. Sometimes we do order a lutetium-based scanning or a DOTA scan, but if there is a key index somewhere in between 20 to 50% on the biopsy, I may have an inclination to order a hybrid scan of FDG and DOTA. That's why I would like to wait for the biopsy. And if the patient is not on any antacids, I would like to order chromogranin A also.
Yeah, so you would order chromogranin A, and going by the symptoms, anything else?
Oh, that's it, ma'am. Chromogranin A, and the symptoms wise, no. Finally, current, I would like to order this, depending upon the mass formation. And if there is any other diagnosis in the mind of, we have many functional neuroendocrine tumors, I may proceed further accordingly.
Yeah. Dr. Viraj, are you there? You were to be on the panel.
Yes, madam.
Any new tests that you know of?
No, madam. I think so.
To diagnose the NET, anything? You are having so many now blood-based tests. So any blood-based test which can diagnose neuroendocrine tumors?
No, madam.
It has not come to India, but it is there abroad, and it's becoming very important nowadays. Anyway, I'll come to that. So, this patient's chromogranin level A was high. The urine 5-HIA was also raised. A sonography showed these metastases. So this is the new test. It is called the NET test. It is a messenger RNA detection in the blood. It's a liquid biopsy for neuroendocrine neoplasm and defines molecular genomic signatures. It is accurate, automated, miniaturized, and the data can be transferred globally. It is cloud-based, and it is 90% accurate for the diagnosis of especially gastrointestinal NETs. And so this is an important test which is making its way abroad for the diagnosis of these tumors. And it may soon replace chromogranin A, but of course in our country we would still have to do with it because it's very expensive. Now, what is the optimal imaging in this case? So, I mean, some of you have already spoken about that. I'd like to ask Dr. Jagdish Kothari is there. He was to be on the panel as well.
Yes, madam.
Yeah. So, what would be your line of imaging here?
I think, as mentioned before by Dr. Lele also, that would like to have a PET scan, the dual, the somatostatin as well as FDG, to really find out what are we really dealing with, the kind of uptake on both the scan, which would ultimately guide us in further management of this patient.
Now, just coming to certain points about the imaging, if you have liver limited disease and you're contemplating surgical options for the liver, would you just go by the DOTA scan, or what more would you do to know exactly whether those lesions are resectable and how many lesions are there? Dr. Kothari and Dr. Deepak Chhabra?
Yeah, so madam, you are right. I have first screening PET scan for me, and then depending upon what we are dealing with, MRI of the liver with specific contrast medium would be very, very useful if I am contemplating anything as a surgical plan in my patient. Dr. Deepak may add anything.
Yeah, Dr. Deepak?
Yeah, so I would like to just add on to this that if I have to restrict to this particular case, or for that matter, to your question, and how do you detect multiple primaries in small intestine? Now, this is a very interesting and a very challenging situation where often the primaries in the small intestine are so small that they can be missed by the regular conventional contrast, the positive contrast that we give in the CT scan. So when you have a patient who's got features of this, and when we are suspecting a small contrast or something like a CT enteroclysis, where I would ask them to load the bowel with water, and then the appearance of the polypoidal lesions in a water enhanced contrast medium is much more better. That is number one. What Dr. Jagdish Kothari also pointed out is very relevant, that of course management is based on depending on the findings of our theranostics, or what you call as the therapeutic doses or the diagnostic doses used in the radionuclide kind of scans. And that would give us an idea about what we are dealing with, how much of liver metastasis, and to confront in cases of surgery, we may need a multimodality investigation like an MRI, or for that matter, gadolinium contrast MRIs, so as to differentiate the number of metastases should we be planning for resections.
So, this is the CT scans, and you can see that there is a mesenteric mass, and you can see radiating fibrosis. And of course, you can see a small primary. And as you mentioned, that usually you give a negative contrast so that these are visible. And this patient had multiple lesions in the liver, in segment 8 being the largest. And you can see these liver lesions. And just to show that, the gallium dotatate, this is approved as per the guidelines just published in 2018, and in most of the scenarios you would use it The only place where it may not be useful is in the surveillance. So it's category 5 over there. And in as far as the JEPNET is concerned, you all have covered this, that you would use the SSTR PET CT, and in certain circumstances you would also use the FDG PET. So now you can see that this is just a illustration of multiple primaries in the small intestine. Not in this case, but in one of the cases, and this is how the negative contrast can show it up. So now, would you consider, coming back to the surgeons, Dr. Deepak, would you consider the patient a candidate for surgery?
All right. So in the presence of liver metastasis, especially in a situation where it is a functional tumor, I would consider this patient as a candidate for surgery. Two main reasons. One is functionality, and second is when it comes to small bowels, there is always a chance of obstruction at some point of time. So these people do become candidates for surgery. So
Dr. Jagdish Kothari, can I say that surgery is a must for all small intestinal NENs because of the possibility of obstruction and the nodal metastasis causing mesenteric fibrosis and ischemia of the bowel?
Yes, so this is typical. I always ask to my DNB students that what this appearance is known as on CT scan, and it is a hurricane appearance which is known as. And you are very right that this is because of lot of desmoplasia in the mesentery, and ultimately this leads to eventual obstruction in this patient. And if the patient performance status is good, then we should offer a surgery. And as mentioned before, there would be such a small tumor you may found on exploration that on one of the occasions we found 8 primaries in small intestine, which were actually not seen on any of the imaging. About 3 to 4 were not seen on the imaging. So one must always look for all these primaries and do the proper resection.
So my second question is, now this patient is symptomatic and has a carcinoid syndrome. So how would you stabilize the patient before surgery? Anybody, Dr. Deepak Chabra or the medical oncologist, Dr. Abhishek Kakru or Dr. Nagendra Sharma?
Yeah, ma'am. So I think I was going to intervene previously also before even, not even surgery. I think we discussed about biopsy. In such a case, probably stabilizing the patient before the biopsy also would be a very important thing to do, because many a times you see biopsying the carcinoid leads to more problems rather than the biopsy being done. So stabilization would be with somatostatin analogs, short-acting ones, and probably follow together with the long-acting ones before the surgery is done.
So do the surgeons agree with that?
Yes, I think I would tend to agree. I would tend to agree to that. The first symptoms the patient is presenting with is hot flushes as well as carcinoid type of symptoms. We need to control the symptomatology for sure, which takes up upper hand. So priority is sandostatin LAR.
Okay. So I won't go too much into the details of the perioperative because this is more of like a multidisciplinary. So I just want to ask Dr. Ameya Purane, in Tata Hospital, have you found what is your incidence? I mean, you are in the imaging department as well. So you all do the negative contrast and multiple lesions in the small intestine?
Yeah, we follow the same protocol of using negative oral contrast, especially when we are dealing with small bowel NATs. That is a very standard practice that is followed.
Yes.
And it has helped us in adding increment to, normally we have very prominent single lesion that we pick up on a regular conventional CT scan, but adding a negative contrast helps us in picking up multifocal sites. So that is a standard protocol which we also follow.
Yeah.
In addition, when we are doing a gallium dotatate, we use a triple phase CT as well. So in order to pick up the liver lesions in a better way.
So this is very important, that negative contrast is always used when you're imaging for gastrointestinal net and also the triple phase contrast. So when this is some of the, in one of the preceptorship programs, this was mentioned as one of the considerations for surgery in small intestinal nets. And what is important is that those patients who have surgery did much better than those who were just maintained on somatostatin analogs. This is the surgery. We have covered this, so I need not go into details of this. And of course, this is just to show that if the nodal metastasis is higher, and I think Dr. Jagdish Kothari could comment on this, then it may become inoperable, right? If the artery is encased at the origin. Okay, so
that's correct. Yeah. So in the advantage is that we are generally dealing with ileal nets, and my contraindication to surgery would be proximal SMA. So this is many a times spared in the ileal nets, and otherwise, yes, if the major artery is involved, I should be careful.
Yeah. So the patient underwent resection and radio frequency of a few of the lesions in the liver. The histopathology was a G1 tumor with a MIB index of less than 2%, well differentiated. And you can see, so it came into the G1 category. The clinical condition, the patient improved after surgery, but had recurrence of hot flushes. Of course, she had disease in the liver that was not totally eliminated. I didn't have the gallium DOTA pictures with me to show you, but it was done and it just showed the multiple lesions in the liver and the primary tumor as well. Now coming to our medical oncologist, now we would have to order some systemic treatment for this patient. So what are the factors you take into consideration when you want to decide on the systemic therapy? Can I come to Dr. Nagendra Sharma?
Yes, ma'am. So the most important thing is, which determines the treatment per se, is the performance status of the patient, whether the patient is in a good performance status or not. Second thing is, what is the volume of the disease, how much rapidity of the response we want. Third thing is the case system of the patient, whether it's a high grade tumor or it's a grade 2 tumor, intermediate type of tumor. Sometimes we are always having in the back of our mind that the radiology surpasses histopathology many times. So when we are doing both the scans, as one of the panelists also mentioned also, that when we are doing DOTA scan, along with that we are doing the FDG PET, by which we will be able to figure it out what exactly we are going. Now we are having the PETNet score also, so which we mentioned also. So if we are having a FDG PET which is equal to which is the score of 3 is equal when SSRI uptake and this both are equal. So most important thing, performance status of the patient. Second, case system of the patient. Then whether it's what is the grade of the tumor, what is the volume of the disease, and how much rapid we want the response. So these are the major factors which will determine what the treatment is going to be.
Doctor, for shortage of time, Dr. Randeep and Dr. Abhishek, do you want to add anything?
No, ma'am, nothing. I think he has covered all the points. The primary tumor and the extent of metastasis will be very important.
Yeah, so I mean, these are all. So, you know, it does away with a lot of confusion if you stick to these points and then come up with a plan of treatment for the patient. So now what treatment would you offer? Somatostatin analog, PRRT, interferon, everolimus, sunitinib, chemotherapy, or liver-directed therapy? So can I begin with Dr. Randeep Singh?
If the scan is showing only metastasis to the liver, and if we can, because we know that we can easily do a liver directed therapy with a bland embolization, and these tumors don't even need transarterial chemotherapies or others. And if liver is the only site and those metastases are unresectable, I would like to go for a liver directed therapy and keep the patient on observation and then switch to SSA on progression. On the contrary, if liver directed therapy is not possible, then I would start them with SSA, and we have only one SSA available in India, and that will be an octreotide long acting preparation.
Dr. Abhishek, you would like to mention what you would want to do?
Agreed, ma'am. I fully agree with what Dr. Randeep has said. I think she was still symptomatic after the primary surgery and liver was the culprit. So I
Yeah.
think we should be chasing the liver.
Yeah. Dr. Viraj?
Yes, madam. I agree. Liver-directed therapy would be the way to go in this patient since the patient is still symptomatic. The question what I had was during the surgery of the bowel, was the surgery for liver attempted in this case?
RFA was done.
RFA was.
Yeah.
So,
Now,
doctor,
Madam, I would just like to interrupt. I think when the patient's symptoms are recurring, I think I would rather go on a re-imaging of this patient to just make sure whether the disease is restricted to the liver or if there is anything which is beyond that. Now, as what Dr. Randeep and the other medical oncology colleagues have said, that if the disease is restricted to the liver, it makes things easier, and putting 1:1 liver-directed therapy takes an upper option. But of course, somatostatin analogs have given a symptom relief to begin with. So I don't see any harm in continuing a somatostatin analog if in case it can control the symptom. Now, going on the gallium dotatate or any other functional imaging, if you have more lesions which have come up over a period of time, I think then PRRT should be in the armamentarium.
so now I would like to ask Dr. Mayank and Dr. Ameya Puranik, what do they
Yes,
think
ma'am.
about PRRT as the option in this patient?
Well, PRRT given a chance would definitely benefit the patient, ma'am, because the patient is having a low grade of tumor, and we know now that we can give good benefit to the patient with least possible side effects. So
Yeah.
I don't see any reason why PRRT should not be, considered, and especially if the disease has escaped the liver, so it is any other within the abdomen or extra abdominal out of liver metastatic disease, then of course that becomes the primary indication for a PRRT.
Yeah. And what about Dr. Ameya?
Yes, actually, one more thing which I wanted to add is since this patient has shown new lesions after the first gallium dotatate, a grade 1 progressing so fast, and FDG PET should also be added in this patient.
No, not progressing. See, only the primary was resected and only some lesions were RFA'd. So patient still had disease in the liver. So
fine.
Yeah.
So in that case, if the patient has gallium avidity in those lesions, I think PRRT should be the preferred option. We also have the option of intra-arterial PRRT, which we do at Tata Memorial, especially for large size liver lesions. So that is, so I think more than going for TACE or any other bland embolization, I think PRRT should be the preferred option for liver metastasis in a NET.
Yeah, so the second line option after SSA in the guidelines today is PRRT going after the Nettle study, and I won't go into the details because it was nicely covered by the previous speaker. Now, so PRRT would be an option.
Can I interrupt? I think Dr. Amey and Dr. Manas want to, they want to start the PRRT without a progression on SSA, if I could get it right.
See,
maybe as the first line in this case.
No, ma'am. No, sir. The symptoms are coming back, and before the disease gets, as we know, there is some grading change. I think it's a basic way of treatment. It should not cause much of concern.
I think Dr. Randeep, I think we are missing the point. What Madam was trying to say, and as we would see from PROMIT study, that every patient who's resected for a small bowel would anyways be kept on somatostatin receptor analog. So probably what Madam, correct me if I'm wrong, your question was directed that patient was already on somatostatin and still she has having symptoms now.
Yeah.
My only question, Madam, would be that, this patient was offered RFA. So assuming that he had probably lesions which were countable, and under those circumstances, probably we should look for, do we have options of any curative resection treatment in this
There
patient?
were bilobar met, so surgery was considered, but it was not taken into account because of the bilobar distribution. So now, of course, the house is divided between PRRT and liver-directed therapy. Now, there are no head-on comparisons. This is a very good meta-analysis published by Hoffland et al. In 2019. And they looked at almost 31 trials and about a large number of patients. But most of the studies were single arm studies. And you can see that SSA, interferon alpha, liver directed therapy, and PRRT. I mean, these are the ones which are giving the maximum benefit to the patients from the point of view of overall symptom relief, and also somewhat reduction in the 5-HIA that varies between the strategies. So although this was a meta-analysis of single arm studies, you'll never get a head-on comparison. But I think this is a very important study giving you exactly how your carcinoid syndrome patients are going to be benefited from the various therapies. And that is why if you see over here, the neuroendocrine starting with long-acting SSAs after surgery, liver dominant disease, you do have possibility of cytoreduction, as Dr. Jagdish Kothari mentioned. But then liver directed therapies is one. Second thing is also the PRRT, though here it has been put below that. The second thing is dose escalation of the SSA. So I want to know, I won't talk of telotrestat because it's not available. Does any of the medical oncologists actually increase the dose of SSA?
I have done it in 2-3 patients. It is well tolerated, except the blood sugar which goes deranged. So I have gone till 90 mg, and yes, there is a benefit of around 6 to 8 months. So I have done it in 3 patients. They could tolerate. Tolerability is not an issue. You have to start monitoring sugar. And 60 mg is easily tolerable. Once you go to 90 mg or you reduce 60 mg 3 weekly and monitor sugar, you can do it, especially in patients who cannot afford any further therapy. And earlier, when you were not having, I mean, it's an earlier time when we were not having everolimus and sunitinib approval. 4-5 years, I used to do it.
So this is the Clarinet Forte is the study which was just published, I mean, presented recently, where they looked at, reducing the frequency of the lanreotide to 2 weeks. And they found that it was a single arm open label. And you see that those patients who have a Ki-67 of less than 10%, they are the ones who benefit. So if you want to use this strategy, you should use it in patients who have a Ki-67 of less than 10%. And the Reminate study also looks at consolidation lanreotide. Of course, we don't have this drug, but there can be some extrapolation. And on the horizon is adjuvant SSA combinations and consolidation. So these are all the new things on the horizon for the SSAs. And what next, So the patient did undergo PRRT. Now, I just want to know from Dr. Ameya, because you all have very aggressive liver-directed therapy interventional radiologist, plus you have PRRT. How do you sequence this? Do you need to keep a gap between them?
So you are talking about PRRT and the liver-directed therapy.
Yes.
We prefer to do the PR. I mean, that all depends on the type of liver metastasis that we have. If we have liver metastasis which are amenable to any liver-directed therapy, we first go ahead keeping in mind the curative intent. If there are diffuse liver metastasis, as we had in this case, which are bilobar, then PRRT is the preferred option. And then if we manage to achieve a good response following PRRT, then we sequence the liver-directed therapy subsequently.
So you'd keep a gap. They say it should be minimum 3 months. 3 to 6 months gap between
the gap between each PRRT is 3 months, and subsequent liver-directed therapy and PRRT, there is no such recommendation of a gap between intravenous PRRT and liver-directed therapy.
Yeah. So then this was the first therapy was done, and then there was a 50% reduction. The second therapy was given 2 months later. The patient refused for further PRRTs, though she was responding. So how do you assess the response, Dr. Mayank and Dr. Purani?
Well, A is the symptomatic response, ma'am. Then we can also do the imaging and the biochemical response we can look at. But the most important would be, am I audible? The most important would be to do a DOTA scan following maybe 2.5-3 months after the cycle has been given. But
what are the criteria for assessing response?
Madam, we can follow the persist criteria or the resist criteria to assess the response, and also that would depend upon the timing when you have given the treatment, after how much of time. If you do it too early, because we see that patients, they are very sonograms are done, the size based criteria are not favoring, there is symptomatic response to the patient. So in these cases, I would say that it is good to wait for about 3 months and then do some form of either if cost is an issue, even a sonography would be a good option. But if costs are not an issue, then to go for a DOTA scan and then evaluate. Look at the size, the uptake values, and one can nicely and easily assess the response.
Dr. Smruti, you have 5 minutes left.
Yeah, so after 5 months, again, the itching started. And then, of course, for recurrent symptoms, this patient was put on everolimus. As you know, that the RADIANT-4 data clearly shows that everolimus is an option. So the patient is presently on everolimus with partial reduction in the symptoms. This is a 35-year-old male, and he had, just to show you, a bulky tail pancreas lesion with multiple lesions in the liver, and it showed a G2 tumor with high chromogranin, and this is the receptor scan. So is there a role of surgery in advanced PANNET, Dr. Deepak? Very briefly, because we're running short of time.
For very advanced pancreatic metastasis, no major role of surgery unless and until the primary is life-threatening. Apart from that, no major role.
Okay. Dr. Jagdish Kothari, what is your approach to localized PANNET?
Yeah, so non-metastatic localized PANNET, it would be always a choice, is the surgery first.
Yes. What about if it was a men one, you would observe or you would operate?
Men one.
Yeah, because sometimes they say that these patients can have a small tumor going for a long time. So in them, you may observe even a pancreatic NEN. So now coming to what is the approach? Wait and watch, SSA, chemotherapy, targeted, PRRT, Dr. Randeep Singh?
It is, ma'am, as you said, I had 1 or 2 patients who were absolutely observed if their key index was less than 2%, and yes, they were not having any symptoms. Definitely, you shall observe them. So 2-3 criteria, their key index shall be less than 2%, no carcinoid syndrome, and it's clearly an unresectable disease. We can observe, because whatever the patients have been taken on PROMET trial as well as on RADIANT trials have been those patients who have been progressing on symptomatically in PROMET and or on previous therapies, whether we call it as NETR or RADIANT.
But
I would like to start this patient on SSA. If
Dr. Randeep, I think here we are talking about the pancreatic.
Pancreatic, and the patient is the KI 67 was 15%.
Yes, in 15% here the observation will not be an option. Yes. Yeah. And I would like to start with SSA as the first line.
Doctor, quickly, Dr. Kakku, Abhishek and Dr. Nagendra, quick, because we are short of time.
Yeah, I do agree with Dr. Randeep, sir. So it depends on the burden of the disease and the aggressiveness. So based on that, if the patient is having an indolent disease or low KS7, you can observe. Less than 2%, it's better to observe and keep the patient on surveillance. If the patient is having aggressive disease and burden is high, you can go ahead with SSR, like SSA, or you can start sunitinib, everolimus also, depending on the burden of the disease and aggressiveness. Last resort will be like which you have mentioned, that the chemotherapy, that will be the last one, the high volume diseases and the KS7s are quite high, like 25% or beyond, then only the chemotherapy options will be opted. So in that also, other options like if the metastatic setting is there, you can use CAPTEM or etocarbo also to some extent. But I am not having any hands-on experience with the doxorubicin and 5FU as of now. But low volume, the disease, if the burden is low, aggressiveness is less, observation is the best approach. Otherwise, go ahead with sunitinib or everolimus. And if it is a high KC7, high aggressiveness tumor, go ahead with chemotherapy.
Yeah, it's 15%, and patient was highly symptomatic. So the patient was on capecitabine temozolomide, completed 4 cycles after CT scan suggestive of progressive disease. You can see the efficacy of Captum in PanNet. The PFS is around 16 months, varying to around 29 months. And this is the latest data on Captum. And you can see here that this is a randomized study, and it was really beneficial in those patients. So then the patient was advised PRRT. So what is the benefit of PRRT in PanNet, Dr. Amia?
Yeah, definitely. When we have such bulky disease, which is well arterialized and showing high grade somatostatin receptor expression, in a case of 15% Ki67, I think PRRT should be the preferred option. Add to it an FDG PET. If it is positive, then add Captem to PRRT. And I think that is the most suited treatment for a pancreatic NET, which is metastatic.
Yeah. So you see, although the NETTER study was only for small intestinal, and now the NETTER 2 is looking at others as well. And the FDA has approved PRRT for other locations as well. Here the patient progressed and was started on everolimus, and presently the patient is on everolimus. And
Ma'am, can you please conclude? Time is over.
Yeah. So just the last bit, this was the newer therapies. You can see lenvatinib is one of the options, though it is not FDA approved. It is easily available, but the Chinese drug is the most important. And the last thing is the cabozantinib is on the horizon. So these are the important therapies. Last bit, the immune checkpoint inhibitors have no role as yet, but these are the ongoing studies. And the last thing is, I think you all know about it. You have already spoken about it. So I think we can conclude on this. This is just to show you that results of the systemic approaches in G3 nets. So even in G3 net, though the data is sparse, you can use Captum temozolomide, everolimus sunitinib, data is sparse, and in colorectal G3 net, poor response to even chemotherapy. So this is what I would like to conclude, that it's a heterogeneous disease with varied options. Somatostatin analogs have a mainstay of treatment. You have targeted agents for certain G1, G2 tumors. You have chemotherapy for progressive PanNet and G3-NEN, and newer options are emerging, but the checkpoint inhibitors as yet have not made their dent here. And these are the recently published ESMO guidelines in 2020. So with this, I'd like to thank the panelists as well as the organizers for giving me this opportunity.